I can't say it, I'll be in trouble here. Okay, I'm recording now. Indirect assessment of arterial disease. Like I said, I actually owned one of these pieces of equipment. I didn't end up using it a lot. I've never worked in a dedicated, well, I have worked in dedicated labs, but I still did not manage to really get my hands on these very often. So, but this is pretty simple concepts. It's something that you could, a lot of places might just have the nurse do, or the MA can perform these exams. These are really simple. The interpretation and really understanding might not be so simple, but setting up the machine and going boop, they could probably do that. Anyone could do that. So, indirect assessment, PAD, peripheral arterial disease. That's kind of the big. You've probably seen commercials on that for PAD or PAD. That's just a catch-all phrase. For the most part, it's plaque. Most arterial disease throughout the body is plaque. PAOD is what your book, and I had to look that one up. Actually, I had to read it, but it was, I'm not familiar with PAOD, but it's the same difference, right? Peripheral arterial occlusive disease. I just don't know how to pronounce it. PAOD. And once again, catch-all phrase for everything. Now, one of the biggest symptoms is simply claudication. Claudication, this is a big word. You're going to hear this all the time out there in the field. It simply means, in Latin, I think, to limp. So claudication, to limp. Usually when we're talking about claudication, and I had little extra notes in here that went away, apparently. This is usually arterial disease, but venous claudication is a thing too. I had written down here. I don't know what happened. Just from a little box in the book there. It was spinal issues. So that could be stenosis, a slipped disc. What do they call it? Herniated disc. Herniated disc. I've got one of those. It's really fun. And then just in general, osteoarthritis. In other words, arthritis. Arthritis of the hips, arthritis of the spine. So a lot of times when we get the patient in there, we're ruling out these other things. I'm sorry, I shouldn't say that. We may be ruling out arterial disease, which would support, okay, yeah, the doctor's like, yeah, I wasn't so sure it was arterial. I think this person has a spinal stenosis. Let's get them an MRI, that kind of stuff. Venous claudication is a thing too, although hopefully your doctor and you will have a different, have an idea of what to expect from the two different claudications. Remember, an arterial claudication is not enough blood going into the leg, and more specifically, not enough high or normal pressure blood going into the leg, whereas venous stasis can cause claudication, but those legs tend to be filled with blood, and blood that they cannot move out. So that causes problems too. So venous insufficiency will cause a claudication. Surprisingly, and that's a little bit of tongue-in-cheek, it hurts when the arteries are not doing their job. hurts. It hurts like hell when blood does not flow normally. Of course, that includes torsion. Torsion of any organ is incredibly painful. Well, occlusion and stenosis kind of has the same effect. It's almost, blood's not getting to where it needs to be. So when we have occlusion and or stenosis, it is usually proximal to the pain. So for instance, if your calf hurts, you may have a popliteal stenosis. In other words, if you have a popliteal stenosis, it's not likely that your buttocks hurts. It's more likely that whatever's downstream, not getting the blood supplier, is what's hurting. So it's a pretty obvious statement, but still needs to be said. I had some more notes here too. Okay, interesting. That's all right. It was only a few small things that I apparently have lost here. This is kind of just some words here. Pallor, whitening of the skin. We normally don't expect the skin to whiten, but what can happen is if you raise leg, and by the way, people usually have venous disease or arterial disease. I don't think I ever saw a patient with at least bad disease of both, probably because they're dead. So it's either one or the other. So if you have someone with arterial disease, they prefer, by the way, to have their legs facing, their legs dependent. In other words, they prefer to be sitting up or sitting in a chair so blood is helped going into the leg. If you raise their legs, if they're laying on their back and you raise their legs up above their heart, it can turn white, or obviously, turn a more pale color. Rubor, or reddening of the skin, that can be caused by going back from a raised to dependent. So you put their feet back down and the blood makes it in. Back to the leg turning white, just remember, like I was saying, the veins are working so the blood is draining out of the leg pretty well, but the artery's not replacing the blood. So that's why the skin can turn more pale, and dependent is just more of a rush back in. Well, let me actually be a little more specific. Most of us, when we put our legs down, they don't change color. Or for that matter, when we put them up, they don't change color. Pallor, because the blood's not resupplying the leg. That kind of makes sense. Rubor, though, the reddening of skin, it might not make as much sense, except you have to think about this. Normally, our arterioles, a good percentage of them are vasoconstricted. Well, you and I, we have vasoconstricted arterioles when we're resting. So when we put our feet back down, we don't have a ton of blood going in because we have most of our arterioles are vasoconstricted. Only a few are wide open in order to feed the leg. But people who have occlusive stenosis disease, their arterioles are wide open. These are vasodilated. And so the blood, as it travels in, it can travel, a lot of blood can go in. And that's the key, guys. It is how much blood to extent, but it's how much blood under the correct blood pressure. That's really important. Your book mentions blue toe. Another word for it, believe it or not, is trash foot. Trash foot. Sounds very professional. Often an aneurysm, which produces a thrombus. So like a lot of times people who have trash foot, they actually have an aneurysm in the popliteal artery. And we know that aneurysms, because the blood comes in and expands and suddenly swirls around and slows down, people can get thrombus in arteries in certain cases, and a large enough aneurysm is a case. So sometimes it's thrombus that can cause blue toe or trash foot. That can be from loose plaque, just like a stroke, except it's not going to your brain, it's going to your foot. An emboli, either a thromboemboli in the case of thrombus, or a plaque emboli. Plaque emboli, I guess. Can't remember the term for that. It must be plaque emboli. Has dislodged and clogged a distal artery. And as you think about that, so, you know, if you have an artery with a thrombus or something that is an emboli that is broken loose, well, it's going downstream, right? So it's going to go to your foot. You lose your foot that way, by the way. But if it's a deep vein and that loses a thromboemboli, that's going to go back up to your heart and into your lungs. So in the case of DVTs, that's why they're deadly, because they'll go to the lung, and if it's big enough, it'll take out a whole lung there. All right. Then we have Raynaud's phenomenon, or Raynaud's disease. That is a vasospasm that is way too strong. So in other words, vasoconstriction, but like every single artery is vasoconstricted. No blood is actually traveling through the system. And usually Raynaud's is in the fingers, can be in the toes as well. What's that? You can make a cameo. My daughter has Raynaud's phenomenon. Do you have it in both your toes and your fingers?
I've never really had it in my fingers. I have it in my toes.
You have it in your toes. So she probably has it. Sometimes we just don't know why. It's idiopathic. But because I'm a mean dad, we took her skiing a few times, and she got pretty decent frostbite. And we suspect that damage that it caused is causing her a repeat. So because now, sure enough, she gets, anytime her toes get cold, she's in trouble of the entire toe turning white, like all of them, I mean, like corpse white, really, really pretty. So primary is often idiopathic. It's actually also, there are certain, because we had to get our daughter tested for, there are certain connective tissue diseases that are associated with Raynaud's, like primary Raynaud's. Secondary Raynaud's is trauma, vibration trauma. So if you ride a motorcycle all the time, and it's like off-road especially, the whole time, to the point where your hands get numb, you know, that kind of vibration injury, that could actually cause that. We're going to swing back to Raynaud's at the end of the chapter. We just kind of mention it, goes away, and then towards the end, it's like, oh yeah, there it is again. So that's what my notes do, and so that's what we're going to do. Okay, patient prep. Always, 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 no matter what your exam is, ask your patient questions. You guys are in OBGYN. If you do not ask whether or not your patient has both of their ovaries, you will end up measuring something, calling it an ovary, and it's not, and then it's rather embarrassing. Same thing here, critically important with PAD to help you make the correct decisions and look in the right places. You could really spend a lot of time, like I did as a new, fairly new tech who had like zero training in this. I spent a lot of time just doing stupid stuff. And if I had known more at the time, if I'd asked more questions at the time too, I could have narrowed down my search. So what are your symptoms? How far can you walk before you have to stop, or before you get severe pain? And that tells you something. If they could walk a mile before they have to stop, yeah, it might be arterial, but probably not. It might be other things going on. If they walk to the end of the driveway and they have to stop by the mailbox, wait for the pain to go away, and then walk back to their house, that might be peripheral arterial disease. Do you have a history of stroke, myocardial infarction and a heart attack, hypertension, diabetes mellitus, and hyperlipidemia, in other words, high cholesterol? Do you smoke? How much? And do you have a family history of any of these diseases? And I would say more so in arterial disease, that's a part of the exam. If you're not asking those questions, I mean, it's literally a part, it's like you don't get paid. So you have to ask those questions. If the nurse has already asked, that's fine too, as long as you have access to the answers. So we're going to have our patients supine, no standing for these, for the most part. Warm. We don't want over vasoconstriction. When we're chilly, we vasoconstrict more of our peripheral subcutaneous arteries because we're trying to keep warmth more central, and that can kind of mess up our results. So you want your patient warm. The patient should be resting while you're setting up and resting while you're asking those previous questions. You don't need them standing there and then laying down and start your exam. That's not going to work well for you. Okay, so we're talking about indirect assessments. So the first one, really the easiest one, is the simple ABI. And I'm very proud of my little ABI guy here. He's just a little cross-eyed, but he'll make it. So ABI is just really simply that. Ankle brachial. Ankle over the brachial. In other words, we divide one of those by one of those, and we get an index, a ratio. Save it otherwise. Okay, so pretty easy. You could do this with one cuff, one limb at a time, right, left, brachials, ankles, or maybe two cuffs, because you generally don't use the same size cuff. But here we have an ABI machine, because you are lucky enough to have one of these. So you set it up. I think I sent a video out on basically how to set these up. You want them firm. If it's a machine, you want to make sure that each one of these, this is actually the right brachial, and this is going to be the left brachial, and so forth. If you don't want to mix them up, right and left. And we certainly don't want to mix up brachial and ankle cuffs, because obviously that's really going to mess up the system here. I wrote 20% down here as a little reminder. When we put cuffs on, you know what I thought? I do have that. Nope, I guess I didn't. When you put cuffs on, the width should be the width of the cuff. In other words, all right, here, let's just draw. There's our cuff rolled out. This diameter here, that width should be 20% greater than limb diameter. So on this person's limb, then, if you were to put it up next to their bicep, their limb, their actual bicep should be about that big, maybe just slightly smaller. You want, you know, there's your 20% greater than. Okay, I just wanted to mention that. This gets a little messy here. Whoop. Okay, now Bernoulli. Bum, bum, bum. I love Bernoulli. I bet you guys are all excited to have him back in your lives here. Whoops, delta P, right? The change in blood pressure is equal to 4 V subset 2, which is really a delta V. I don't know why they write it this way. In other words, the change in velocity, 4 times the change in the velocity squared. That's a big number, remember? And so when our blood travels through a stenosis, we have a big time pressure drop. Big time pressure drop, and it never comes back. So, having said that, we're going to look at, actually, let's go down to our worksheet here. So we have this guy all set up. Brachial and ankles are set up. And we have this worksheet. Let's get you up and out of the way here. Okay. Whoa. I feel like I must have 2 versions of this saved, because even stuff that I saved yesterday is not here. That's a little concerning. Looks like 99% is here, so that's good. Okay. We have our standard numbers here. Most of your worksheets are going to have this right here, so you don't have to go searching for it. Frankly, neither was the doctor. These are systolic only. I'm sorry. This is the actual A, B, I's, I should say down here is systolic pressure only. We're not measuring diastolic. So there's no 120 over something, it's just simply 120. In fact, let's make our first 120 millimeters of mercury. So the right arm has a 120 millimeters. But let's say the left arm has 80. Now that's a really big difference. I mean, you can expect some difference. Most of it is just operator error or machine error. But 120 and 80, in fact, anything more than 20 millimeters of mercury between the right and left arms is a problem. So let's assume, we're going to assume that 120 is correct. That means something's going on in the left arm. We know from experience the actual arm we don't know from experience, because you haven't learned that yet. My other classes know from experience that the actual arm, we don't tend to get a lot of plaque in the arm. We get some, and if you have a really bad problem with plaque, you'll have arm plaque. We do get it in the subclavian. So, get a little plaque right here, perhaps, in the subclavian artery. That blood is forced through, and voila, we have low pressure here. By the way, you guys, anyone remember, just nod if you do, and you could be lying to me until I pick you out. Who's the blonde there? Oh, back. All right. So if you have plaque, let's see, plaque right here, what kind of waveform might you have in the vertebral artery? We got our little bunny sign. This person having plaque right there, having low systolic pressure in the arm, they're actually in need of a carotid exam. Okay, let's move forward. So we've already diagnosed one thing on this person, but we also need to find out what's going on in the rest of the body. So let's see, right ankle, dorsalis pedis, 105, posterior tib, 110. These are systolic only. Left ankle, dorsalis pedis, 90, and posterior tib is that. We'll say that too is an 80. Okay, so if we're just looking at this alone, we might have some plaque up in the left subclavian artery, but now it looks like we may have plaque somewhere else. This kind of between 120 and 105, probably not bad. It's probably within normal. Theoretically, we have the same blood pressure throughout our arterial system, but realistically, doesn't always work out. It could just be the cuffs. But so between 120 and 105, 120 and 110, we're going to probably say probably normal. Normal. I'm going to put a question mark. I'm pretty sure it's going to come out normal. We'll do the math. Probably over here though, not so normal. So this person has left-sided problems. Now, all we could say here, let's get a little, we need an artery colored red. We're going to have an aorta, and then it splits into legs. So there's our beautiful blood vessels on this person. If we're normal on this side, but apparently abnormal on this side, and it's both right, the dorsalis pedis and the posterior tib, we probably have something somewhere between somewhere high inside the pelvis. I see you're hiding your face there, Rebecca. Smiling faces. All right. We probably have disease starting here. It's not going to be all the way up here. If it were here in the aorta itself, both legs would probably have problems, right? That makes sense? So starting in the common iliac artery in the hip, all the way down the popliteal maybe, or it could be that both the dorsalis pedis and the posterior tibs are diseased. So we'll say somewhere in the, so really the entire left leg. So this has given us information that says there is disease and it's in the left side, but we really don't know. We don't know that that one is there where I put it. We don't know over here if it's here, 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 or here. We just don't know. But we know there's something going on. Okay, so let's fill these numbers in. I just made these numbers up, so I'm going to pull my phone out. Let's see. Right ABI, highest ankle. Okay, well, that was 110. Let's just make this, we can see that a little better. 110. So we chose the higher of the two. Highest ankle on the left. Oh, my entire, this is so weird. I know I had this. That's really strange. Okay, highest ankle on the left, 90. Highest right or left. So we always use the higher of the two brachials. So in this case, will be 120 and 120. So obviously 110 divided by 120 is going to be close to 1. So divided by 120, 0.92. 0.92 is my ABI on the right. We'll look at that, what that means in a second. Come on, Kurt, learn how to use your phone. And 90 divided by 120. Oh, that's not too bad, I think. 0.75. So those are my two answers. Those are the two questions the doctor's going to have for you. Let me zoom up a little bit here. So 0.92, 0.75. All right, 0.92, the right is normal. 0.9, oops. 92, 9. Normal, we fell well within normal, so we're good there. The left, though, what did I say, 0.75? Yes, is mild and actually on the borderline between mild and moderate, 0.75 on the left. So this person's definitely showing some signs of disease. And obviously, as our numbers get smaller and smaller, we're getting closer and closer to severity or tissue damage. Why, and this happens a lot, incompressible, 1.3 or above, or I should say greater than 1.3, 1.31 or above. You guys know who these people are? Diabetes mellitus. Most likely diabetes mellitus. The people with diabetes get arterial, I'm sorry, I get the two words mixed up. Arteriosclerosis. In other words, they might not even have plaque, although they probably do, but they might not have plaque. What they end up having is, well, calcifications in the walls of the vessels. And so literally they're incompressible. I've had patients where once again, I learned this on the job. And I just compress until, the cuff was about ready to cut their leg off. And I still would get blood flow going through, and the doctor's like, yeah, don't do that. It's incompressible. They have arterial sclerosis. Oh, and I'll go look that up because I didn't know what I was talking about at the time. I still don't really. You guys think I do, that's all that matters. All right. So anything very high numbers, in other words, of course, that would simply mean that the blood pressure in the ankle would be much higher than the arm. You don't get arterial sclerosis in the arms. All the bad stuff happens in the legs. You get arterial sclerosis in the legs, not in the arms. So their arms are still compressible. Their legs are not. So that's the ABI exam. Once again, do you have disease? Do you not have disease? You're really not narrowing it down much at all. Okay, oh, we're lying. We'll be done early today. Okay. Plethysmography. Once I finally learned how to pronounce it, it was my favorite word of all time. Plethysmography. Segmental limb pressures. So these blood pressure cuffs can do more than you would normally expect. You think a blood pressure cuff just squeezes your arm until the artery collapses, and then you usually with a stethoscope and they figure out what your blood pressure is. And this machine will do that. This machine will go through, find all your pressures for you. So it's like an enhanced ABI. It's an ABI in more than just your ankles, though. It does. So it's not really just an ABI. It does pressures throughout. And then after it does its pressures, it comes back and squeezes the arm or the leg at 80. I want to say it's around 80 millimeters mercury, and then it just holds it there. And what happens is, every time your artery beats, this guy over here, this cuff, these are arrows, I know it's really sloppy, gets slightly bigger. Your entire arm, your entire leg, every time your heart beats, gets slightly bigger. It's obviously it's microscopic, but when we have this whole cuff around you, it can feel that, and it literally puts a pressure wave back to the machine, and you end out with what's called just a PVR trace. So that just that little tiny bit of increased size actually can be seen by the machine. It's not as accurate as our Doppler, but it's pretty good. So air plethysmography, also called pulse volume recording. There used to be some others. There used to be strain gauge, where something would go around and there'd be like a little strain gauge, and every time the heart would beat, the strain gauge would get pulled. And I can't remember what that was called. Maybe it was strain gauge plethysmography or something to that effect, but definitely never seen those. I have seen the PVRs. So now PVR, you're gonna have a machine. The ABI, you might. I used to do ABIs without a machine. That was fun. But PVRs, you're going to have one. And it could be a 4-cuff PVR, meaning there are 4 cuffs in the leg, or it could be a 3-cuff. On certain people, you could take the 4-cuff and just not even use one of them and just go with the 3-cuff method. Each one of these is usually color coded, and there's you put these on carefully. Once again, you don't put the wrong cuff in the wrong place. It's a mistake. So tubes and the cuffs and the little connectors are oftentimes color coded. And you press the button on the machine, and hopefully it just starts doing everything for you. And you end out with a, in this case, a normal PVR recording. This is not a, see, that's weird. I just wrote those in there, but they're still there. Very strange. Okay, you don't care. This is not a normal Doppler. Remember, guys, a Doppler in a leg, a normal Doppler should look like more or less like that, triphasic. You're not going to get that with a PVR. It's not that accurate. It can see the little, that little bump right there is that little bump right there. All right. By the way, on a PVR, this is called a, well, that's kind of called it, in both actually, it's called a dichrotic notch. That's a good thing to have. One of the first signs of either that your cuff isn't on tightly enough, or very mild disease is a pretty normal looking waveform, but without a dichrotic notch. So the dichrotic notch kind of shows that we have triphasic flow. Read my little notes there. Let's just draw a couple more. So this one, once again, is good. Remember, this is just a pressure wave coming from the cuff itself. Let's see. Draw a little. I'll use that functionality here to help me. Let's make it a little worse. Okay. Here, where's the dichrotic notch? That's missing. So that's a bit of a concern. Perhaps tardus parvis. At the top, not quite as sharp, although I'm definitely going to put a question mark on that one. But here, let's draw the next one. And so this will be, we'll call this mild disease. I'm still going to put a question mark because maybe our cuff isn't quite right. But then we're going to come down and definitely now we're talking tardus parvis, blunted wave overall. That's a disease state. And if it looks like this, that's severe. Severe with an E. Okay. Oh, I have some notes here to remind me. Tell you a couple of things. Page 159, just be aware that the image is wrong. I think it's fairly obvious. It's talking about lower extremity and shows an upper extremity. So just keep that in mind if you're looking at that. Also, these images here. Let me just hold it up, guys. You can see both of these are upper extremities. They're both arms, and the second one though talks about a leg. But the other thing about them is that these are not PVRs. These are segmental pressures. So they have perhaps a machine, perhaps not. Perhaps they did it all individually. They've gotten the pressures of the arms and supposedly the legs, but they didn't have a PVR machine. Or if they did, they didn't use it in that way. They used actual Doppler. So there's a lot of variations on this. I've used a continuous wave Doppler with my ABI machine. I've also done a lot of these exams where I'm taking pressures with the cuff, but then I'm doing the Dopplers with my transducer, and then I hand them all in. Some machines, you know, they all kind of come together, but other machines, you don't use the Doppler. So this says segmental pressure in Doppler study, whereas on page 162, 161, 162, this is a segmental pressure and PVR. So the PVR, that's the part where the machine is taking these waveforms for you. Okay. Oh, well, I'll just show you that. This last picture, you could see, so like for instance, these over here, if that were a Doppler, there'd be something seriously wrong, but that's actually normal. Whereas on this side, that's like tardus parvis right here. So right off the bat, this person's entire left leg, sorry, my screen is backwards, so it gets confusing. Their entire left leg is diseased. Actually, it's the same amount of disease throughout, so probably their left iliac artery is diseased, probably. All right. I wanted to go here. So this is fun. We could run them. Normally, echo techs do this. They do stress tests. And it's really great because they're doing it with people who are prone to heart attacks, and they're putting them on a treadmill. That's got to be a little bit hair raising. I mean, not my hair, but. So if we have more questions about the severity, we could run them or we could walk them. We could have the patient walk on a treadmill or have them walk up and down the hall. Preferably, you're probably with them because they probably need your help. This has to be cleared, by the way, to do this. You can't just do this without being cleared for their health. And what would Bernoulli say about exercise and pressure? Delta P is equal 4 times velocity squared. When you exercise, your velocities to your legs are going to go up. Normally, right? Your heart's beating harder, your arterials open up, everything's going to be flowing faster. So what would Bernoulli say? If that's going to go up, our pressure is going to drop even more. And so that's why these folks, by the way, that's why they could rest and they might feel better, but when they exercise, it gets worse because their pressure is dropping even more. They might be getting all the blood they need, but the pressure, if you don't have the pressure, you don't have the exchange of oxygen and nutrients. Okay, so let's do 2 different colors. Let's see, what did this person have above? They had left leg pain. So let's do the right leg first, the right ankle. And we'll do that. That's a nice color, green. And let's see, they started out at 110, right? In either the dorsalis pedis or whatever. So perhaps 0 minutes after exercise, this is post-exercise. So you exercise them, you lay them back down, you quickly take their blood pressure over a period of time. You could also take Dopplers over a period of time, but blood pressure is going to probably tell you more in this case. So maybe they had a little bit of a drop, but you know, over time, their blood pressure came back almost immediately. Within 1 minute, one or 2 minutes, their blood pressure came back to its resting state pretty quickly. And it didn't have a big drop. On the other hand, we have that was the right leg, the left leg. At 0 minutes, perhaps we're down here. And it could be, let's say, oh, did they ever make it back to, no, they didn't. It's down here. And they don't make it back to their left leg resting for, let's say, 6 minutes. That kind of gives us a little more information. You guys understand what happened here? The bigger drop in the left leg was due to Bernoulli. The arterials are staying open longer as well. And it's not until the arterials finally close down over here at 6 minutes that this patient is starting to actually feel a little bit better, perhaps. Whereas on this leg, within a minute, they were back to normal. So that's an exercise stress test, basically, or an exercise testing on the leg. Oh, that's right. I have a little note over here. You could do post-occlusion, although this is really mean, which is why I like doing it. So post-occlusive, you could put a pressure cuff around the thigh and squeeze it to very high pressure, like let's say 150 millimeters mercury. You shut down the entire leg and you leave it there for like 5 minutes. Now the leg's really screaming for oxygen. And you could do the same thing and see how long it takes before the leg normalizes again. Generally, people are not doing post-occlusive anymore because it's really quite painful, actually, to the patient. Those were the days, though. No, I actually never did it. All right, I know I'm just going on and on and on and on, but we're getting a lot done here. And you guys are able to sit back and relax and watch this while I'm. Okay, just quickly, if we're actually doing a Doppler, this is what our Dopplers look like, right? Triphasic, that's normal. And why? Okay, we know this is abnormal. You might say, well, okay, Mr. S, there's a tardus parvis. And yep, you're right. But look at this. We have over here, we have flow reversal, right? The flow is actually reversing for a moment in time. And then at the end, maybe not, depending on what your state is, no flow. So no flow, and then the heart beats, a little bit of reversal, and no flow again. Here, yeah, we have tardus parvis. We know that's bad. But look at this. No reversal, and in fact, constant forward flow. This person is resting, but their leg is acting as if they're exercising. This is somewhat what your leg looks like after you exercise. We only have triphasic flow when we're resting. As soon as we start exercising, triphasic flow goes away. That's one reason why you have to rest your patient before you start examining. Triphasic flow goes away like that because all the arteries, they open wide open. That Windkessel effect is really no longer a problem because blood's just going through as fast. So it actually turns into this looks like exercise. S-E-C-E, exercise. Yeah, C-I, whatever. I always have trouble with exercise. I get the C and the S. Anyway, so I'll just draw it really poorly, and then that way you're like, did he spell it wrong? I don't know. So, but this looks like exercise. but this person's not exercising, they're resting. That means their muscles are always starving. They're always starving. And so even at rest, the blood is moving forward, forward, forward. And that's why I say it doesn't necessarily matter how much blood is getting to it. It's what pressure is it under. So this person undoubtedly has low blood pressure in that leg. Let's see. Oh, okay, just a couple more concepts, guys. Thoracic outlet, why we're talking about it now? Oh, because we're talking about indirect assessment. We'll talk about thoracic outlet again next chapter or two. So I won't really get into it too much right here, but you can see I've drawn a beautiful arm and arteries and veins, and I drew a clavicle here and an artery and vein going underneath that clavicle. And so that's kind of a, if you believe in evolution, we weren't initially meant to be standing up with, we're supposed to be on all fours, right? Evolution didn't really think about this. That's a problem that a lot of people have. Now, I know a lot of you guys don't raise your hand and ask questions, but when you're a kid, you're ever raising your hand and your arm would go numb? If your arm would numb quickly, you might have thoracic outlet. And so these people, actually most of them, most people with thoracic outlet actually have nerve pinch. But others have thrombosis in the vein because of thoracic outlet or thoracic outlet syndrome. Others, I knew a bodybuilder, and every time he worked out, his veins would just stick out, but they weren't not like a bodybuilder normally sticks out. They were like about to burst, and it was really painful for him. And he had created so much muscle in this area that he actually was compressing his vein every time he worked out. And then so it's a thrombosis of the vein or a pinching of the artery. If you're going to test for this, you're going to want a PPG. Oh, PPG, photo. Anyone else remember? Well, I can't remember what PPG stands for. It's basically, it is infrared. Yeah, infrared light goes right through your skin, barely even sees the skin. It is able to go right through, and it reflects off of red blood cells, and you can get heart rate from that. You could do, it's similar to those oxygen testers, but because oxygenated blood reflects differently than deoxygenated blood. But in any case, in this case, we're not worried about oxygen, we're just worried about blood flow. So you can get a blood flow on your finger with these little PPGs, which is a hell of a lot easier than doing it on the wrist when this person has to move their arm in different positions in order to elicit the thoracic outlet syndrome. I've done that without a PPG, and it was miserable. So thoracic outlet syndrome, fairly common syndrome. Raynaud's, we already talked about. One thing you could do for that is simply, once again, a PPG. Here, let's do another line. PPG to the finger. Wrap the finger in a rubber glove or a plastic bag. Put the hand in ice water for, I don't know, half a minute or something, or a minute, and see what kind of response. We all will have a bit of a response. We all vasoconstrict because our body says, ooh, we're cold, we need to keep the middle warm. So we're going to sacrifice the fingers. But people with Raynaud's syndrome have a hypersensitivity to that, and they vasoconstrict like crazy. And that is what my daughter's toes look like, but not her fingers. Yeah, that's all we need. That was the big follow-up on Raynaud's. I mean, what else am I going to say? Allen test, if you know this man, you passed the Allen test. So congratulations. Okay, no, this one's actually pretty cool. And this is the last thing we're going to talk about. Yeah, that's the last thing we'll talk about. This is kind of cool. So let's see, this person's, they're getting, this is the radial, oops. Radial artery. Oh God, I was like, what is it called? Ulnar artery over here. Well, let me tell you a little bit about the anatomy. Maybe I'll draw right on top of these hands because I cannot draw hands at all. Let me use the color black because. So let's zoom in. Zoom. You guys could try this on your own. Really? You're answering the phone now, dogs? All right. You could try this on your own. And what this person's doing, they're first squeezing their hand. Squeezing. They're exsanguating the blood, which is kind of a hard word to say, but they're getting the blood out of their hand. And then you could do it to yourself. They're pushing down hard on one of their arteries to see what happens. Well, looks like the blood re-entered my hand pretty well. I could try that again. You can see how pale my hand gets when I'm doing this. And I could squeeze my other artery. Yeah, that. My arteries seem to fill up pretty well. This person does not. This person's crazy. So what happens is you have an artery that comes in. Here's a radial artery, and it loops with the ulnar. And there's actually two levels. There's an anterior and a posterior. Well, that looks like one artery. I meant to draw two arteries there. And of course, there's branches. But some people, this person, they don't have a full arch. And I just realized that if I use my eraser, I'll erase their hand. That's okay. Ooh. I'll just draw a new. This person has an artery there and an artery like that. They don't meet in the middle. This suddenly becomes rather important when you need that artery. Let's say this person needs heart surgery and the surgeon wants to come in and why is the Allen test in this? Well, anyway, the surgeon comes in and they want to harvest the radial artery, which is pretty common. Can you imagine the damage that could be done on this person if the radial artery is harvested? Blood will find its way to the thumb and the first finger and part of that middle finger, but there might be enough tissue damage where they could actually lose part of their hand. So not a good thing. So a radial artery harvesting. The other thing that we might be looking for is pre-surgery for kidneys, for kidney disease, dialysis, pre-dialysis surgery, Because what happens is you have usually the radial artery and then a vein. Let's just use blue here. And the veins here, and what will happen is that we connect the two. We make a fistula. And that's designed so that blood just goes like that, and actually this artery still continues on down. But in this situation, if you create this dialysis fistula and you don't realize that this person has inadequate circulation in their hand, you could have a couple of things happen. Well, one, all the blood just bypasses and you simply cut off the blood supply to the radial artery. You could also get a steal phenomenon, just like the bunny rabbit we talked about earlier, the steal phenomenon in the vertebral artery and the subclavian and vertebral arteries. You could actually have blood get sucked backwards. So it's even worse. It's actually draining the hand of blood that's already not well circulated. So that is why we may do an Allen test. Truth be told, this particular is a sideshow. You would do something similar to this, except you would use PPGs. It's more accurate, more reproducible, and it's something you could actually take a picture of and put into your report rather than trying to take a picture of a person's hand like that. It doesn't. So this is a bit of a sideshow. It used to not be. This used to be the way they do it, but now it's become a bit of a sideshow to do this visually. But you put PPGs on the fingers. You watch whether or not blood is coming back into the hand using the PPG. It's a little bit better. Okay. I